That's where you catch the moment of hope, the moment of self-belief, and that is what is to be nurtured. So, don't waste time assessing your view of people's employability. If they want to work, then take them in the programme. They won't all get through, but don't start making prejudgments. The next one, again, is simple sounding, but not so easy to do. Employment support is integrated with treatment. Now, this means, effectively, that instead of having the treatment team do its work and then passing the person over when the treatment team thinks they're ready to be employed, you actually have the employment worker in the team, working alongside them. The team's caseload is their caseload. They are in on the critical decisions. They talk about employability and employment all the time with their colleagues, CPNs, with the psychiatrists, with the psychologists, and the whole team works together to do it. And preferably, and indeed in most cases where I know it works, they actually sit in the same office. So I was in Clacton the other day doing a fidelity review. I'll tell you what that is in a minute. A fidelity review, and actually the employment worker was sitting opposite the psychiatrist. They were all hot desking. And I said, well, how's the communication? He said, well, I just lean across the desk, actually. That's how it works. That's how it really should work. What is very important also is that employment interventions appear in the treatment record. These are interventions. They shouldn't be separated, so everyone knows what is going on. That's quite difficult to do sometimes, actually. 3, competitive employment is the goal. This means that basically, if people want a paid job, you get them a paid job. That is the focus of the programme. It may be that on the route to that, they may wish to do other things. You may decide that a work experience placement, a limited one is good. People sometimes want to do some volunteering. Well, let them go and do some volunteering. That's good. But always with a purpose, and the purpose is paid competitive employment. Deviate from that and the message is all wrong. That's, you know, people want a job, get them a job. That's the important bit. And, of course, sometimes the way services are commissioned and paid for militates against this. So, in one of our centres of excellence in Sussex, for example, then we found that actually the team was commissioned, the supported employment team was commissioned with outcomes that were volunteering, education, employment, and they had equal numbers of each. And of course, what happened? Well, lots of volunteering, quite a lot of education, almost no employment. What we said was really, if you want to volunteering, good, education, great. If you want to get people into work, your employment specialists have to focus on that, because that's difficult, and that's what they need to be focused on. Rapid job search. This is the place and train bit as against train and place. Rapid, well, pretty much as soon as people enter the service. It doesn't mean they get placed in employment quickly, necessarily. 6 to 8 months, usually I think is about the average. But the job search, the reality of getting a job starts immediately. That's the whole purpose of trying to get people into a situation where they believe that you are actually going to get them a job. And that's very important. And the teams who operate this actually measure the time and record the time to job search, so we know how long it takes for them to start job searching. Job finding and all assistance is individualised. Well, yeah, that's easy. Everyone does individual services, of course. But actually also quite a lot of people think, well, you know, actually this person may want to do a particular job, but it's not realistic for them, so we'll get them a job that happens to be available, whether they want it or not. All the evidence suggests that people who get the jobs that they aspire to do, or something like, get them quicker, stay in them longer. Sometimes it's quite a tricky one to get through the initial period when someone comes into the service and it appears that they are unrealistic in their expectations, in their hopes and fears. The one story I like is the one the person who wanted to be an airline pilot, and supported employment work wasn't fazed by this, though it was quite clear that this person was never going to be an airline pilot. And so, after a lot of discussion, he said, well, look, let's go and see what an airline pilot does. Let's go on an open day to Heathrow Airport, because it was quite near. So, took him to Heathrow Airport, They had a really good discussion, and it was quite clear that what the guy really wanted was, he liked uniforms and he wanted to be near planes. And what he particularly was impressed by, and because they talked to him and seemed to be treating him like human beings, baggage handlers. And so he got a placement as a baggage handler and eventually a job as a baggage handler. Because the employment worker said, well, didn't say immediately, oh, this guy's delusional, let's think of something else. Tried to interpret what it was, worked at it, didn't destroy the hope, tried to build on what was there. The other thing about this job finding, all assistance is individualised, is possibly the most difficult bit of the whole application, actually. Because what you're trying to do as a support worker, an employment specialist, is to get in contact with employers in a way that enables the person you want them to employ, bypasses conventional recruitment procedures. Think about it. If our folks have to fill in forms, if they have to go through the whole process, the so-called equal opportunities process, then they don't even get to first base. One look at their record or lack of it, one look at the form, so the idea actually is for the employment specialist to work very hard at getting to know employers, so the relationship of trust is built up with the employer. In the fidelity scale, which is the kind of checklist of things that you ought to be doing if you're doing it right, then the high fidelity worker is talking directly to employers 6 times a week, either by phone or by actually visiting. And it's the thing that most employment specialists find most difficult. And it's the one thing that really, really makes the difference. Once you're out there, instead of pointing people in the direction, saying, oh well, here's a job advert, here's the paper, why don't you go along, etc., etc. The employment specialist who is the most active, who is going along to meet the employer with the person, who's going to try and get the point where the employer is really interested and feels that not only that he has a potential employee, but someone who's going to help that employee and him, then you've got a successful work. And it takes a while to do that. People don't come necessarily with those skills. 1 or 2 do, but most employment specialists don't. Flying hours, they need to actually do it a bit. 6, follow-along support is continuous. This is, of course, one of the most difficult things to fund, because actually what you are asking is that once people are in work, instead of saying, yes, okay, good, job done, then, cheerio. Actually, of course, the reality is that people often don't keep the jobs for very long. Sometimes they find the first period very difficult. Sometimes they may wish to move jobs because it's just not the right job for them. The point about being in supported employment is that the specialist, the employment support worker, is there for them to help them through that period of transition and subsequent transitions. And often, actually, it sounds terrifying, of course, to people who fund it because it's kind of unlimited commitment. But actually, in practice, it's much less terrifying. Often it's a matter of being just in touch, of knowing that you have phone contact, giving people a ring occasionally, and really only being able to move in once things are really going wrong. It's quite difficult sometimes, particularly when the clinical team has discharged the person, to actually get them to agree to see the person again when things start going wrong again. But that's part of it. That's why you work with the clinical team, because they understand these things. And research seems to show that the longer people are in supported employment, the longer they work, the more they earn, the better their health. And that's where the payoff is. And the final one, financial planning is provided, by which we mean, of course, people need to feel secure about their income, that they're going to be better off in work, that the benefits trap is not going to be sprung and they're going to find themselves without income, etc., etc. So expert financial planning needed, and this is so in all countries that do individual placement and support. Now the key to success is not picking and choosing from these, but doing them all together. What the Americans have done, and which is now used both as a standard research tool and as a self-evaluation tool for service improvement, is called a 25-point fidelity scale, where you score your service against these various principles and try and improve. And the research evidence is very clear. The better your score, the better your outcomes. Ooh. Up until 2007, there have been 16 published and qualifying randomised controlled trials. In fact, there is one that's published recently that I've not included, chiefly because it wasn't actually a control, it wasn't actually a trial of IPS. I can talk about that if you want, the so-called SWAN trial. 11 of the randomised controlled trials were high fidelity services. In other words, you could say they were actually testing IPS as against something else. And most of them were in the United States, but one very big one, 6 European countries, equalised trial, led by Professor Tom Burns from Oxford, was in UK and in 5 other European countries. This graph shows you how consistent the results are. The one with the green circle around it is the European trial. You will notice that the dark blue line, and we're talking about the ones here to the right, the dark blue line has employment rates of people entering the service, anything to nearly 80%, and at the lowest, somewhere around 30–40%, but with a median of about 55%. The control groups, the other services, vocational rehabilitation, clubhouses, sheltered work, etc., about half that in each case. So pretty conclusive, really, significant results. And in the equalised trial, they chose in each country the best of the existing vocational services. So it wasn't that they were comparing IPS with rubbish here. And it is actually, I mean, you know, getting 55% of those entering the service into paid competitive employment is quite an achievement, I think. So pretty much, as far as the research is concerned, job done. That's conclusive. A few little details of the equalised trial. 55% in the IPS section gained employment, 28% in the traditional service. And this is a reminder of all people with schizophrenia. The qualifying diagnosis was that the person had schizophrenia. In terms of dropout rate, 13% dropped out of the IPS service, 45% out of traditional service. And here was the one that really surprised Professor Burns. In the IPS service, only 20% were readmitted to hospital, whereas 31% in traditional service. He had thought, as most psychiatrists do, actually, or have done, that actually it might well produce an effect that quite a lot of people got made worse by work. Well, actually, that didn't prove to be the case. He changed his views as a result of this. No deterioration in health associated with employment. Looking at the follow-up studies, because it's been going a long time in the United States, and as I said earlier, work outcomes improve over time. If you stick at it, and if people stick at it, then they work longer, they earn more, they have fewer jobs, they stay where they are. Employment is always associated with improved self-esteem, symptom control, quality of life. On the whole, not much change in terms of choice of employment. Certainly not as much. And among those who become regular workers, and this is the subject of one of the papers that I put on the desk outside, called Commissioning What Works, the economic data show that over time, those who become regular workers, which is about a third of them, savings in healthcare over 10 years are enormous, really significant, because of course the healthcare of the people in this group is very expensive, and if you can save it, then you've made massive savings all the way down the line. And so really, we're talking about something that not only has a case in terms of what people want, a case in terms of people's health, but also cost benefit. What about from an actual service? Well, I've taken Rachel's service in South West London. They haven't completely, well, they haven't in 2008 anyway, completely got IPS into all their teams, even after 10 years. So it wasn't something that just happened, not like instant coffee, not like put in and pour hot water. But they had 11 out of the 18 teams.